is a 76-year-old woman with multiple myeloma, a bone marrow cancer of plasma cells, if you don't know that, presents with dyspnea and lower extremity edema. Her ECG demonstrates low voltage QRS complexes in each lead. Echocardiography shows a markedly increased ventricular thickness, enlargement of both atria, and a normal left ventricular ejection fraction. What is the most likely diagnosis? What are your thoughts? Okay, so I'm seeing D, delta. You all agree with delta? And the answer is yes. It's restrictive cardiomyopathy. Remember, our three forms of cardiomyopathy were dilated, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. And a couple of things that put somebody at risk of restrictive cardiomyopathy are like your deposition diseases, amyloidosis, and those types of things. But radiation exposure is also a risk for developing restrictive cardiomyopathy. So she had radiation exposure with multiple myeloma treatments. Other things that points to this is, remember we said low voltage QRSs are present in EKGs with somebody who has restrictive cardiomyopathy. And then we also said you tend to get this increased ventricular thickness because you have all that stuff kind of getting deposited and that fibrosis that occurs. And then the other thing is, it says there's a normal left ventricular ejection fraction. Remember, dilated cardiomyopathy is a systolic problem. So it's a ejection problem. Hypertrophic cardiomyopathy and restrictive cardiomyopathy, those are diastolic dysfunctions, and it is a filling problem. But the ventricle will squeeze whatever blood it gets out of it, okay? So several things kind of pointing to this that allows you to kind of rule out some things. And then we didn't really talk about arrhythmogenic right ventricular cardiomyopathy, so that's never going to be an option. So, okay. All right, our next one, 40-year-old man presents with progressive exertional dyspnea. Cardiac examination is notable for an S4 and a harsh systolic crescendo decrescendo murmur along the left sternal border, so Erb's point, while supine, which increases in intensity after standing. Which of the following statements is correct? What are your thoughts? So what's the condition being described? Which cardiomyopathy is being described in this? Here in hypertrophic, right? Yep. So this is a hypertrophic, and you can kind of tell simply by the murmur, okay? So the murmur associated with hypertrophic cardiomyopathy is most commonly heard at Erb's point, okay? And it tends to be a systolic murmur. Compare that to the other murmurs that you hear at Erb's point, which is your aortic regurgitation and your pulmonic regurgitation. Those are diastolic murmurs, okay? So, so this is a hypertrophic cardiomyopathy. So what would you think the answer is then for this? C, Charlie? Yeah. So you're going to see that asymmetric septal hypertrophy. That's the most common location. But the big thing is that asymmetrical hypertrophy in conditions like aortic stenosis or left ventricular hypertrophy due to poorly controlled hypertension, you get a symmetric hypertrophy of the left ventricle. In hypertrophic cardiomyopathy, it's that asymmetric pattern, okay? All right, last one. Which of the following is not a recognized cause of dilated cardiomyopathy? Remember, there's lots of things that can cause dilated cardiomyopathy, which is a systolic dysfunction. But which one is not a cause? Here in Bravo. Okay, correct. So mitral stenosis. Mitral stenosis causes a dilation of the left atria because it has to have a higher pressure, higher volume to open the mitral valve, but that doesn't translate to the ventricle. And remember, dilated cardiomyopathy, you get a dilation and an enlargement of all 4 chambers. Okay, so mitral stenosis just really truly impacts the left atria, so that's not going to be an all 4 chamber problem. But all these other things are common causes for it. So most common is this idiopathic / viral. Alcohol, excessive alcohol consumption can cause it. In heart disease, if alcohol is listed there, assume that's probably the reason. And then anthracycline chemotherapy are cardiotoxic substances, and that can lead to the development of dilated cardiomyopathy. Okay. Questions about our last lecture? So let's move on to our last lecture of new material. And this is kind of a hodgepodge of things because the PANTS blueprint requires us to talk about these things, but trying to figure out, well, where do you put these in sequence kind of left us to talk about orthostatic hypotension, syncope, and then our shock conditions, okay? So all of these are on the PANTS blueprint, which is why we have to talk about them, but kind of squeezing them together into one lecture was one of the best ways to kind of get this knocked out and make this lecture worth your while. But we're going to first talk about orthostatic hypotension. Now remember, your body has a very controlled, tightly regulated system where it monitors the second-to-second changes in your blood pressure, and it will make second-to-second inputs to try to adjust and correct that blood pressure to make sure that blood is circulating, organs are getting perfused appropriately, and to basically support the function of that organ. Okay. So when you have a condition when you have a patient with orthostatic hypotension, the criteria to be able to diagnose somebody with orthostatic hypotension is you see either a 20 millimeter drop in the systolic blood pressure or a 10 millimeter drop in the diastolic pressure several minutes after standing when compared to the laying down blood pressures. Okay. So that is the definition of orthostatic, is at least a 20 millimeter drop in systolic or at least a 10 millimeter drop in the diastolic pressure. Okay. And usually what can cause this is it could be that those regulatory systems, those autonomic pressure detectors that kind of are spread out throughout the body, maybe they're not functioning well, or maybe you just don't have the volume there for your heart, your cardiovascular system to support that needed perfusion. Okay, so those are some of the more common causes of it. It could also be medications. One of the easiest reflexes is when you stand up, pressure drops a little bit, heart rate increases to try to improve that cardiac output. Well, what if I'm on a beta blocker or I'm on the hydropyridine calcium channel blocker that keeps my heart rate from increasing like it should in this condition? Okay, so medications can cause this or make somebody at risk of developing this. In normal physiology, if we didn't have our compensatory mechanisms in place, when you stand up, you can have upwards of 1,000 milliliters of blood pool in your lower extremities. Average person has about 5 liters of blood, so 1/5 of your blood volume gets stuck in the lower extremities without those compensatory changes. But the body kind of senses this, and it immediately starts to activate those compensatory mechanisms to the point where typically what we see in somebody who is otherwise healthy, volume appropriate, is we get a little drop in our systolic, maybe 5 to 10 millimeters at most. We actually get an increase in our diastolic pressure, and we see an increase in our heart rate to kind of compensate for that cardiac output drop because of that stroke volume drop. Okay? But if you have a patient who these regulatory systems are not working, or they have that volume down to the point where heart rate can't make up for the difference, then they can develop that excessive drop in pressures. And you can see, in your elderly patients, these folks have so many other medical comorbidities, tissues, other things are just kind of wearing out, right? Those baroreceptors that should regulate the pressures don't work as well as they should. And you can see a lot of patients with orthostatic hypotension are going to be in your elderly patients. But it's also the age group of patients you don't want falling. You're elderly, right? If they break a hip, it's almost certain mortality for them. Medications, so antihypertensives is a big one. This is why it's important to appropriately diagnose your hypertensive patients, and that's why we need those multiple blood pressures being abnormal to actually give a diagnosis of hypertension and why we would start medications. Because if I have a person come in with just a single isolated elevated pressure for the many reasons that you might have a temporary elevation in your blood pressure, and I start hypertensives on those patients, well, the problem is going to be they're going to be having a low blood pressure at a normal state, which is going to increase the risk of these folks passing out because the medication is prohibiting or interfering with those regulatory systems. And then there's other medical conditions like Parkinson's and stuff like that, multiple sclerosis, that can also affect the body's ability to compensate for gravity and the circulatory changes with gravity. This is not a list I expect you to memorize, but this is just kind of an illustration of all of the different medications and classes of medications that have orthostatic hypotension as a side effect of it, okay? So there's a lot of things that we can give to our patients that can make them prone or more susceptible to developing this condition. So how are they going to present? Well, it could be that maybe they ate a meal and now you have all that extra blood volume getting shunted over to the GI tract to help with the digestion of that meal. So you're taking, especially if you have somebody who already has a reduced vascular volume, you're sending a lot of that volume to the gut. That's going to take it away from other organs, i.e. central nervous system. Okay. Could be from prolonged standing. We always see this in when we are expected as military members to stand at attention for long periods of time, and then people lock their knees and they fall. It's because they're in the process of locking the knees, they're decreasing that venous return, and so your preload drops, and so your cardiac output drops to the point where the brain is not receiving the necessary blood to keep it working and functioning properly. But as we saw with our, in the video clip, some of the symptoms of this could be, they stand up and they get visual blurring, they start getting that tunnel vision where the peripheries of the vision starts to turn black and kind of starts to encroach in. They may feel weak, lightheaded, dizzy, and then if it's severe enough, they may actually pass out like you see with our little gentleman over here. But another thing that's kind of interesting about orthostatic hypotension is the patients may have a particular kind of headache where we call what we call a coat hanger headache, which it just kind of follows the distribution. Imagine in your blouse or your shirt, you put a coat hanger in there and you have it sit there. In that region, the patients are going to have a headache in that distribution if they have orthostatic hypotension. So how are you going to take your orthostatics or your tilts. I don't know if you've heard one term over the other or whatever, but they're the same thing, okay? So the process is you have them lay flat for 5 minutes. You take their blood pressure and their pulse. Then you have them sit up 5 minutes, take blood pressure, pulse again, and then stand up, take blood pressure and pulse. And ultimately what you're doing is you're comparing that standing changes to that laying values. And the only reason that we really do that sitting one is if you have somebody who's at risk of having this condition, if they sit up and you already meet the criteria for orthostatic hypotension, chances are if you have them actually stand up that they're going to pass out and maybe get injured that way. So it kind of serves as an intermediate step that I can assess what their status is before I put them up in the standing position and they pass out. So that's why you're going to do it in those 3 positions. But it's important that you give that couple of minutes after the position change before you take the blood pressure, because you want to see what the change is, not in that acute situation, because you remember you have all those compensatory mechanisms that start to kick in, and maybe you're going to take their vitals before those mechanisms have kicked in and made up for that change in gravity. So you want to see, is this a chronic thing, meaning that it's not something that just needs that acute compensatory changes to occur. You want to see if this is something that is prolonged. When you go to do your workup, you want to start getting labs or doing testing that kind of helps you rule in potential causes of their orthostatic hypotension. Maybe they are anemic, so maybe they're an elderly male who anemia is going to be their initial symptom or sign that they have colon cancer, right? Maybe you have your young female patient who has iron deficiency anemia from blood loss. So looking at the blood counts is important because that is an easy thing to assess and can lead to this condition. Electrolyte abnormalities, especially if they have a GI illness and they're vomiting and diarrhea, it's going to cause all kinds of shifts in your electrolytes. So let's look at those and see if maybe those are present. Let's look at the kidney function because that can give me an idea also of if this patient is dehydrated or not. Glucose is always a good thing to check to make sure you don't have too low glucose. And then other things like electrocardiogram, looking for any kind of like weird arrhythmias. And then there's some other studies that can be done if you're not really finding anything. One of those would be like syphilis. Okay. So how are you going to treat it? Well, there's pharmacologic treatment, but what can we do in the meantime, or that is non-pharmacologic and more of a conservative treatments to manage this condition? Well, one is, if it's a medication-induced thing, let's see if they actually need to be on that medication. Maybe we just need to adjust the dosage a little bit. Maybe their beta blocker dose is too high, and I just need to cut it down so that the heart rate can rebound better in these positional changes. If they're dehydrated, okay, let's give them IV fluids. This would be an indication for IV fluids if they are having orthostatic changes because of how bad their volume depletion is. But let's say you have an elderly patient who has a baroreceptor problem, probably not going to get better, right? The damage is already done to those baroreceptors. So what can we do for that patient? Well, one would be, instead of having that patient wake up and then jump out of bed right away, let's have and give the body the opportunity to kind of adjust to some gravitational changes. So if they have like an adjustable base bed, have them raise the head of the bed. And now put some gravity on the gravity forces on the cardiovascular system so that it can start to function to accommodate that. Okay, so let's have them sit up or raise the head of the bed first. Let's give them compression stockings because remember we have all that excessive pooling of blood in the lower extremities with standing. Let's give them compression stockings to limit how much pooling can occur and also to assist the veins in getting that blood out of the lower extremities and returning it back to the heart. Exercise is always a good thing, so in your elderly patients, even if it is just having them walking around the block, we don't want them to be just sitting on the couch. We want to push them. We want to challenge the cardiovascular system so that it can become stronger and work better in these situations. If low preload is a problem, let's do things to improve that. So let's actually give them salt, and let's have them drink more water. And with that salt, they should absorb and retain more water in the intravascular system. And then the last thing would be, as the patient goes to stand up, kind of think of these as like your anti-G straining maneuvers that you see in your pointy nose aircraft pilots who are exposed to high Gs. You're going to do things to kind of squeeze that blood out of the legs and back up to the heart. So tensing the legs, the calf muscles as you're standing. We talked about hand grip isometric exercises with the dynamic auscultation maneuvers, but what that does is that increases afterload, right? So let me have them do that. I'm increasing my afterload, I'm increasing my pressure. So I'm hoping that I can keep that perfusion pressure up, so I'm actually getting that perfusion of the central nervous system so they don't experience this pre-syncopal or syncopal episodes. But in your patients who can't tolerate or the conservative treatments don't work, typically what we're thinking about is like doing a fludrocortisone or a steroid that can help with regulating the blood pressures better. Midodrine is a great agent to help with blood pressures. When I was working in the ICU during residency, we had one ICU attending who put all of our septic patients on midodrine, and it significantly reduced their vasopressor requirements. But then we had another attending come in who hated midodrine and took midodrine off every patient, and all of a sudden all their pressor requirements went up. So we ended up putting the patients back on midodrine because it wasn't working to support the blood pressure in our critically ill patients. So midodrine is a great agent to help raise that blood pressure. And then if the condition is due to eating, then octreotide can also can help in this specific population to help prevent these episodes. Okay? So octreotide, midodrine, and fludrocortisone are treatments for orthostatic hypotension in patients where conservative treatments don't work. Okay. Now, one thing that PANTS does not require us to talk about is POTS, or the postural orthostatic tachycardia syndrome. Okay, you may know somebody with POTS. It's not really well understood why somebody experiences these episodes. There's lots of theories as far as what the cause is, to include like mental health, but we really don't know yet. It's also a chicken and the egg kind of thing. You know, if you think that this is a mental health condition, is it caused from the mental health, or do they have mental health anxiety, that kind of stuff, because they're almost passing out and they feel their heart rates racing and everything like that every time they change positions? So it's hard. We don't know what the true cause of this and the mechanisms are in place. So POTS, patients with POTS are going to be exceedingly difficult to manage and treat because we just don't know what the cause truly is. Questions about orthostatic hypotension before we move on? So let's talk about syncope now. So the definition of syncope is this abrupt, let's see, where's my thing here? Okay. Abrupt and transient loss of consciousness due to a global cerebral hypoperfusion that is usually characterized by a rapid spontaneous recovery. So compare that to the definition of a stroke or a cerebrovascular accident, right? Where you have a focal blood supply or perfusion problem to the brain. You normally don't think of with stroke syncope, right? So because there's a difference in the pathophysiology between the two. This, in syncope, there is a global hypoperfusion of the brain resulting in this abrupt but transient loss of consciousness, okay? But this is, if you're working in the ER, probably one of the most common complaints that you're going to have to evaluate. The list of potential causes of this is just so broad, and some of the causes are not easily ruled out in your emergency room. So this is going to be one of the more common pathologies or complaints that is going to require hospital admission. And when we look through the reasons and causes, we'll see why most of these patients get admitted. Okay. It could be from a like a reflex syncope or neural-mediated. This is going to be like your vasovagal syncope that we are familiar with. It could be due to cardiac diseases, so like arrhythmias or something like that. That the things that affect the perfusion and the flow of blood in and out of the heart. It could be psychiatric, and we'll talk about some causes of psychiatric things like pseudo seizures and stuff like that. And then, unfortunately, a large number of cases of syncope remain unexplained, and even though with all the testing that we do, we're just not going to be able to determine why the patient suffered this syncopal episode. But when you look at all the different causes of syncope, you can see, depending on the cause, it could determine what your prognosis, what your life expectancy is. If it's due to vasovagal syncope, you can see that that yellow line kind of trends and tracks along the normal trend path, right? But as you start to get things like unknown cause, your mortality, your prognosis starts to get worse. If it's neurologic causes, then it's even more worse. But then cardiac causes, you can see your chance of survival as the years go on really drops to the point where you're, 18 years or so afterwards, and you have like a 10% chance of still being alive after the initial diagnosis. So, cardiac causes of syncope portend to a worse prognosis. Now, if you like acronyms or mnemonics to help you remember causes, the mnemonic pass out can help you remember all the different causes of syncope. And the first one, the P, is pressure. The typical diagnosis that falls under this umbrella is vasovagal syncope, which typically vasovagal syncope is brought on by a known trigger. Okay, so this is going to be your patient who goes to get their HIV blood draw for medical readiness reasons, and they pass out in the chair because it's the site of needles or the site of blood causes them to lose consciousness. Okay, if you're working in the hospital, one of the most common places you're going to be called for code blue or rapid response, it's going to be the lab or the vaccination clinic. Okay, it's just because of this condition, that vasovagal syncope. What happens with vasovagal syncope, vaso meaning vasodilation, which leads to a drop in blood pressure. And vagal is the heart rate, and you get a drop in heart rate. The pathophysiology of this is a hypotension and a bradycardia. You can imagine this is the opposite of what a normal compensatory change would be, right? If you get a drop in blood pressure, you should get an increase in your heart rate, right? But because of this condition, because of how it functions, you get the drop in heart rate and the drop in blood pressure simultaneously, okay? But these folks, they pass out, you put them on the deck, blood flow starts to return to the brain, blood pressure starts to come up, all that kind of stuff. They come back, and yes, they may be embarrassed, but they are fully alert, and oriented almost immediately. Arrhythmias is the A in pass out, and there's so many different types of arrhythmias that can develop. It could be medication-induced arrhythmias, but it could also be genuine cardiac causes. Typically, you may be able to catch these on your EKG if you happen to have the leads on at the right time. But you may need to do more of that continuous monitoring in order to determine what exactly is the arrhythmia that's causing this, okay? Because the treatment is going to be very different depending on the arrhythmia that caused this episode. The first S in pass out is seizure. These folks, they see you have that witness extremity motions or movements. They come to after the seizure is done and they are very confused. They have that post-ictal period of time. And then sometimes these folks will have symptoms that kind of serve as a prodromal. It's kind of like a trigger so that they know they're about to have a seizure. But not everybody has that. Only about half of people have those prodromal symptoms. So it's important when you have somebody who has a seizure or there's a concern for a seizure to get not only a good history and physical exam for the patient, kind of seeing what symptoms were they having before, what do they remember, and then looking for evidence of like that they lost control, so like loss of bowel or bladder, loss of or tongue biting because they lost the ability to kind of control and not bite their tongues and stuff like that. So looking for physical exam findings of that loss of control. You'll see a lot in BAMC ER with all of our trainees. Pseudo seizures is pretty common. So what ends up happening is you see these seizures, it looks like a seizure, but then you start looking for some of these secondary signs of a seizure and you don't see them because they don't have that true loss of control, loss of function. Okay. So if you're looking at history and you're trying to see what happened before, was there something going on? Micturition syncope is so common as far as a cause of syncope. Micturition is going and urinating. This would be like your elderly male patient with BPH who's having to strain to get urine flow, and he wakes up in the middle of the night because he has to pee 2-3 times a night because of his BPH or because he's on medications that causes him to urinate a lot, and he passes out at the toilet. If they have things like deja vu or jamais vu, other kind of things, tongue biting, then that's more indicative of like a seizure. But you do want to see what witnesses saw, okay? Did they see, that they had these symptoms kind of preceding the syncope or the loss of consciousness? Was the movements or the convulsions, did it occur after they lost consciousness? Because if it did occur after they lost consciousness, then it could be a convulsive syncope. So this would be that tonic-clonic kind of movements that occur because of the syncopal episode, and not the syncopal episode occurred because of the tonic-clonic movement. So it's kind of sequencing of what happened. If witnesses notice that the patient started to be confused, they started not acting normally, and then after they came to, they were confused with that postictal period, then that would be considered concerning for a seizure. Okay, moving on in our pass out. So the next S is sugar. So hypoglycemia can cause this. This is not due to a global hyperperfusion, but it's kind of mimicking a global hyperperfusion because you're not getting the sugar, the glucose, in order to maintain cellular function. Okay, so you're not giving the brain what it needs to function, so the patients are going to pass out. And then cardiac output. So in addition to like arrhythmias, other cardiac conditions can cause the patient to lose consciousness. And this would be like valvular diseases, like your aortic stenosis that we talked about, where you're not really getting that cardiac output because the aortic valve is so stenotic that it's not really letting much blood flow out to meet the demands. Okay. There are some pulmonary problems too that can contribute to output problems. And we'll talk about like forms of shock and stuff like that where you see pulmonary issues leading to that. But if you do have somebody with an output problem, then let's start doing some testing to kind of determine what the cause of this is. Do you hear murmurs? Let's do an echocardiogram and look for problems, lack of function or loss of function. And then moving on, the U is unusual, so this would be like your psychiatric causes of syncope. This could be anxiety attacks, panic attacks, it could be somatization type of disorders that trigger this unusual appearance. So this is basically a diagnosis of exclusion. You can't just assume somebody has psychiatric causes without doing the testing, because it could be they have a cardiac cause that is causing anxiety or panic attacks and stuff like that. And you don't want to just dismiss this as just a pure psychiatric thing without doing that proper cardiac workup. And then transient could be things like TIAs or strokes or other types of things, intracranial things that can affect the perfusion of the brain. And with those, you would want to do head imaging to make sure you're not missing anything. But ultimately, it kind of comes down to when you have somebody with syncope, the mnemonic beach helps you with your history taking. So B is what happened before you lost consciousness. Were you feeling nauseated, vomiting? That would be like, was there an illness there? But also, maybe this is more like a vasovagal kind of thing. What did eyewitnesses see? Did they see the tonic-clonic seizure-like movements or did not? Did they see any other signs or symptoms prior to them passing out? What happened after? When they come to, they regain consciousness. What happened? Are they alert and are they oriented or are they confused in like that post-ictal period? And then what was the circumstances? So were you doing anything? Were you running? Were you sitting on the couch? What happened that precipitated this condition? And then of course, history. So is there a history of this happening? Is there a history of drug use or other toxic use? Is there a family history of cardiac disease? So looking and assessing for things that might put this patient at a high risk of more serious causes of syncope. And here's just, and I don't expect you to memorize this, but this is just a list of things that on your history or on your physical that you could do that would point to, a less concerning cause or low risk factors versus those that are high risk, okay? And one of the things that would be high risk is they passed out during the exertion. So basically kind of pointing to that the heart couldn't keep up with the demand with exertion, okay? And this is just a continuous list. When we talk about anemia, it's not like a borderline anemia. You're actually having a profound anemia, not necessarily to the point of transfusion, but less than 9 typically would put somebody at risk for syncope. And then we'll break for 10 minutes after this, but the way you treat syncope, let's say you've ruled out the cardiac causes, you've ruled out psych stuff, you've ruled out a lot of these other things, you're kind of stuck with maybe this vasovagal, or maybe there's not a known trigger for this syncope. How do we manage this? Well, one would be making sure that you maintain an adequate volume. So making sure you avoid dehydration would be one thing, right? But similar to what we talked about with orthostatic hypotension, those medications could also be used to help support that blood pressure and that perfusion pressure of the central nervous system. So your medications like Minidrin and fludrocortisone are important to help with this. And then of course, if you do have somebody who has an arrhythmia, then maybe they need a pacemaker to prevent these episodes from happening again. So, questions about syncope? All right, let's take 10 minutes, come back, finish up with shock, and then we'll move on to starting our review for the test. Your story to help you decide which one. Well, they need to know what they're filming. It'd be kind of like that's a good question. There are some that we do for a lot of So there are
Well, regular melon.
Yeah. I just know it's bad.
Yeah, so don't associate dysfunction with don't associate so typically what happens, I know we're trying to figure out a better way several they did where people went and did their diplomas and then they went up individually interesting so then transition was let's do the white coat and now we're going to put an hour early and then it's last week and this semester
Was he not? Was he not?
but instead of it being
Yeah. Was he not?
potentially, unless just
It could be like sometimes I mess up when I upload it to Canvas, but like it messes things up. Like I was not like that when I did it. So I was like, answers like, hey, like it doesn't come up with what it's supposed to be. But also, he doesn't download it. He downloads it.
so the big one would be
Also that. Oh, no, you're just like we're back in version. Like, right.
so
Yeah, it's called all for a tribute.
so if you're like patient passing out basically will
He's gonna use up all like the makeup stuff.
so that means
He might take this like more. want an actual tournament. On him, it's more about the rest of the actual location. So you have
To the cardiac. If it's like or if you're
It's been a while.
I remember watching that on YouTube, like when it came out, like the most, like you were, probably the best draft game I've ever had. Just how crazy, always like kids get too, but like, when they break open the food and like just cover themselves. I'm like,
They were definitely taking something they made it.
they're definitely taking something, all the like the little tokens. I'm feeling it.
Everybody in my mind is like, you did one or two.
Oh yeah.
Wanted to get one for the bottom fish.
back to it. So orthostatic hypotension and syncope was one of the things on the PANCE blueprint we needed to talk about still. And then the next one is shock. Okay. So we're going to spend the next part of this lecture talking about the different types of shock. Okay. And it may be a little different from what you have learned in the past, especially if you've done trauma rotations or trauma training, because the hemorrhagic shock, which is the most common cause of shock in a trauma patient, is not in its own category, okay? It actually falls under something, and it falls under a category because of the pathophysiology that's going on in that condition, okay? So what does shock mean? Well, we talked about what the definition of syncope, where it's like this abrupt but transient global hypoperfusion with rapid spontaneous recovery, right? Well, shock is a life-threatening circulatory failure that leads to inadequate perfusion, okay? So it's a inadequate perfusion of your vital organs because of this circulatory failure, okay? And it is life-threatening because it's not transient, okay? If you let somebody exist in a state of shock without doing anything, they will die, okay? So you have to intervene. This is an emergency situation, okay? The 4 types of shock that we need to talk about, according to the PANCE blueprint, is cardiogenic shock, distributive shock, hypovolemic, and then obstructive. But we're going to start first with cardiogenic shock, which we've kind of already talked about when we talked about acute coronary syndromes, right, during block 2. Most common cause of a cardiogenic shock is an anterior wall MI, okay? And the reason for it being an anterior wall is, what's the area of the heart that's affected by an anterior wall MI? It's left ventricle, perfused by the left anterior descending, also known as the widowmaker, right? So that's why anterior wall MIs are most likely to cause this, because the area that's distributed, or the coronary artery that distributes blood or perfuses the anterior wall, perfuses the majority of your left ventricle. And your left ventricle is important for your cardiac output, right? So when you have an anterior wall MI and you lose the majority of your left ventricular function, you lose cardiac output. Cardiac output, or loss of cardiac output, leads to hypotension, which then leads to reduction in your coronary artery perfusion, which then leads to more ischemia, more infarct, which then leads to even further decline in the function of the myocardium, and then you just see this spiral of death that occurs. And unfortunately, because of this condition, and because of potentially the cause being this massive anterior wall MI, even in the hospital, if this were to occur, the patient has a 50% mortality rate. So even though they're in the right place, right time, they don't have the right condition for survival necessarily. So cardiogenic shock should scare you because the mortality rate is very, very high in these patients. Kind of going back to what we talked about, so what happens and why this happens, you get that myocardial dysfunction, you get that loss of function, hypotension, tissue hypoperfusion, but it also starts to hypoperfuse the other vital organs. So then you start going into liver failure, you start going in, having strokes, you start having renal failure. So all the other organ systems start to fail as well because they are not getting the perfusion that they need. And yeah, okay, we'll just continue on. So, so what are you going to see? Because we're not perfusing things, because we have that hypotension, you may start to see loss of renal function, they're not producing urine anymore, they're not perfusing their extremities, so now they have cold extremities. So lots of things you may see on their presentation. Biggest thing going to be, okay, because they're in this shock state, you're going to have an increase in lactic acid because you're not perfusing the body properly, and these organs then convert to a anaerobic metabolism, right? Bringing back some of your biochemistry. And you start to see that lactic acid start to build up. Okay. EKG, okay, great. You may see evidence of that. MI, that's leading to this. You can test for kidney function to make sure, or to see if it's perfusing and if it's working properly or not. But when you go to manage these patients, okay, there is that pulmonary aspect of it, so they are probably going to require a ventilator or some kind of ventilation. But then you're going to need to give them support, to hemodynamic support in order to bring that blood pressure up enough to ensure adequate perfusion, okay? And you can do that hemodynamic support by giving them IV fluids, but you got to be careful because you don't want to give them too much and push them into a heart failure or decompensated heart failure state. But then you also have your vasopressors or your inotropes to help with improving that cardiac output and that perfusion pressure. When you go to give them vasopressors and inotropes, it's important to kind of make sure you're giving them the lowest dose necessary to get your pressure up. Okay, if your goal blood pressure is to have a MAP of 65, don't hit them with dosages of these medications to bring the MAP up to 100, because too much of it has negative impacts as well. So give them the lowest dose necessary to get you to goal, get them perfusing again so you're not having this continued clinical decline. I remember a patient in the ICU who was septic. Family wanted us to continue all things possible. We had the patient on 3 different vasopressors, max dose, and just to get the blood pressure to a MAP of 65. And because of that vasoconstriction was so bad because of the high doses, the fingertips and toe tips started to become necrotic because they were not getting any perfusion because of that vasoconstriction. So you got to be careful with the dosages you give because there are unintended consequences. And then ultimately, if this is because of a heart attack, a STEMI, then they need to go and get revascularization procedures done, i.e. going and getting cardiac stenting done with PCI, or doing a cabbage, or if we can't get them to a place that can do this, then of course doing fibrinolytic therapies within that 30 minutes like we talked about in the acute coronary syndrome time hacks. Okay. But if the tissue is dead, then there are the mechanical circulatory support devices that we could use to help maintain a cardiac output enough to keep them alive, whether it be for heart transplant or to allow the family to say goodbye to their loved one before they pass away. Okay. Now, distributive shock may be a new term for you, okay? But the definition of distributive shock is you get this systemic vasodilation and a loss of blood volume through capillary leakage resulting in decreased organ perfusion. So you're losing volume because of this inappropriate capillary leakage, okay? So you're losing that volume, all that plasma, all that other stuff is leaving and going into your soft tissues inappropriately. And the causes of this is sepsis, so you have an overwhelming infection that's in like the bloodstream that triggers this inappropriate capillary leakage. You could have an anaphylactic shock, anaphylactic reaction to like a food allergen or an insect allergen, or medications, right? All of those can cause an anaphylactic reaction. Throat swells up, lips swell up, mouth swells up, all that kind of stuff, leading to inability to breathe. And then there's the neurogenic shock, which we're not going to really talk too much about because I'll leave that for neuro to kind of talk about it. You probably also talk about it in your emergency medicine course next semester. But ultimately, the pathophysiologic changes that occurs in distributive shock is increased vasodilation leading to increased capillary leakage, which leads to loss of intravascular volume, which leads to a loss of preload, which is a factor in your cardiac output, so your cardiac output drops, and that leads to an inadequate organ perfusion. Okay? So that's the pathophysiologic changes associated with distributive shock. Now, patients who are having septic shock, or the septic shock version of distributive shock, they are going to have fevers. So some folks will call this a warm shock. But if you're having anaphylactic shock or neurogenic shock, you don't have those fevers, so don't get too caught up on that. But you're going to look for other things like the tachypnea, the tachycardia, the hypotension because of the shock part to it, right? Basically showing you that this is a severe condition. When you go to do your workup for these patients, it's going to depend on what the cause of their distributive shock is, okay? If it's an anaphylactic reaction, okay, hopefully they know what the trigger was so that they can learn to avoid that trigger to prevent this from happening in future episodes. You're going to hit them immediately with an EpiPen and then give them steroids to kind of counteract and antihistamines as well to treat this, okay? But the workup for septic shock is going to be the guidelines, the surviving sepsis guidelines, where it kind of emphasizes, one, IV fluids to kind of help support those hemodynamic changes. I want to get blood cultures so I know what bacteria or what infectious agent I'm dealing with and what medications will work against it. And then I got to get them on antibiotics early. And then you're going to do other things to help you with monitoring and assessing how bad is the shock that they are experiencing, okay? Is this shock leading to liver failure? Is this shock leading to renal failure because of that hypoperfusion, or did we catch it early enough before we entered that state? And lactates are always a good test to do to kind of help you monitor, one, to diagnose it, but then also to assess, are you treating this condition properly? Because once you have restored perfusion with oxygenated blood to an organ, then it doesn't rely on that anaerobic metabolism anymore, so the lactic acid should go down. So when you do a subsequent blood draw, you should see that lactate or that lactic acid start to drop if you are managing the hyperperfusion properly. So treatment for sepsis-induced distributive shock, let's do IV fluids, IV antibiotics, and vasopressors to bring that blood pressure up to a minimum level for adequate perfusion. Anaphylactic, we said epinephrine, steroids, antihistamines, and then let's avoid whatever triggered it. And then neurogenic is treating the cause for their neurogenic shock. Questions about distributive? Okay, so inappropriate capillary leakage leading to volume depletion, leading to drop in preload, drop in cardiac output, and then hypoperfusion. Okay. Hypovolemic shock is going to be your hemorrhagic shock and your severe dehydration. Basically, I have lost so much volume that I don't have the volume to perfuse organs properly, okay? So by losing that volume, I reduce my venous return, which leads to a drop in my preload, which then leads to my cardiac output drop, leading to hypoperfusion and everything like that. So, but the two types of hypovolemic shock is hemorrhagic and dehydration. And oppose this to the distributive shock, where it was known as like a warm shock. This is a cold shock because you are just not perfusing the extremities or anything like that with this, okay? You may see, okay, especially if it's a hemorrhagic shock, you may actually see the blood loss, you may see the bleeding present there, but ultimately the treatment is going to be dependent on which version of shock you're dealing with. If it's because of severe dehydration, okay, let's give them IV fluids to rehydrate them, restore that volume. If it's hemorrhagic, yes, you can do initial crystalloids to help bring it up, but ultimately they're going to need some kind of blood product in order to restore that volume depletion because it's just been bleeding out too much. Okay. And then let's finish up with obstructive shock, which is defined when there is an obstruction of the great vessels. And this obstruction of the great vessels could occur either within the vessel itself, so for instance a pulmonary embolism, and you're having a complete occlusion of the pulmonary arteries. That's going to lead to an obstructive shock. But it could also be due to like a cardiac tamponade or pericardial effusion, where all of that pressure presses on the major vessels coming to and from the heart, that the flow of blood through those is affected, okay? So there's internal causes, and then there's kind of external, with external compressive forces causing this obstructive shock. But ultimately what's happening is you get these obstructions, decreases the preload, especially the preload going to the left ventricle. You increase the afterload, so now the heart's having to work harder just to get blood, whatever blood is getting to the left ventricle, out of the left ventricle. And that leads to a drop in your cardiac output. And these folks, because a lot of this tends to be pulmonary, they will have like pulmonary complaints. Because you're in a shock condition, the hypotension is going to be important. And then they may have other things like chest pain or JVD or things like that that kind of shows you that the circulation of the blood is not appropriate in and out of the heart. So when you have somebody with obstructive shock, you ultimately are going to look for the cause, okay? So you may have to do like chest CT scans looking for blood clots in the heart. Fortunately, a chest CT scan also allows you to kind of look for like a pericardial effusion or constrictive pericarditis or other restrictive cardiomyopathy kind of things. You're going to want to do, especially because they're in shock, like an ultrasound to look for cardiac tamponade to see if maybe that's what's causing their obstructive shock. But ultimately, treat whatever the problem is. Try to support the blood pressure while you're trying to figure this out with like crystalloids or vasopressors. If you find that this is because of a large pulmonary embolism, let's go ahead and treat that pulmonary embolism with either invasive surgeries to remove the clot or doing thrombolysis and getting rid of the clot that way. If it's because of cardiac tamponade, then treat it like cardiac tamponade. Stick a needle in the space and draw off that fluid that's causing the tamponade condition itself. So treat the cause of their obstructive shock. And then as you can see, we are now down on the PANTS blueprint to just arrhythmias. And I know you learned these arrhythmias in EKG, but we're going to be talking about why do these arrhythmias develop in the first place, and how do we treat and manage these arrhythmias. So that will all be in block for after our exam on Friday. Questions? Okay, I've got about 30 minutes that I can jump into doing review. That will decrease the amount of time we're here this afternoon. Okay, we're good with jumping into the review? Okay, all right. All right, so with our review, so we kind of took a whirlwind tour of things that are related to the functional impacts of the heart that lead to the heart not functioning properly, leading to reduced cardiac output and those kinds of things. We started our discussion first by talking about valvular heart disease, and we talked about the differences between a stenosis and a regurgitation. Stenosis is the valve should be open or opening, and there's a resistance to it. Okay, so it requires higher pressures, higher volumes to get blood actually circulating past that stenotic valve. Then we talked about how regurgitation is the valve leaflets don't seal properly when they should be closed, and that leads to a leakage of blood going in the wrong direction. Okay, so you, instead of that one-way flow of blood, you get it going backwards. And we talked about knowing which murmurs cause systolic murmurs, or which murmurs are systolic and which murmurs are diastolic. We also talked about how there's a grading system for the different murmurs and how systolic murmurs are graded from 1 to 6, and each one of those numbers has a specific meaning that you have to properly assign to your patient, because that could impact what the workup is and what the treatments are, depending on how loud those murmurs are. And we said pathologic murmurs are all diastolic murmurs. If they are pansystolic or holosystolic, those are pathologic. And then we talked about how if it's late systolic or a continuous murmur, those are all pathologic. And then the last one is a loud murmur where it's graded 3 or greater, then that is a pathologic murmur. If it doesn't fall into that category or in those categories, then they could be, and are most likely, benign in nature. But then we moved on and we started talking about, before we started talking about specific valvular diseases, we talked about the spectrum of group A strep and the presentation of these and the different phases of it, but then also the consequences and complications that you could see in your patients who have this. And the first thing, after you have your acute strep infection, you wait 2 to 3 weeks, then they could develop acute rheumatic fever. And typically that's going to be in your patients who did not receive antibiotics. Okay, it's about a 3% risk of non-treated group A strep tonsillitis that they develop acute rheumatic fever. And the valves that typically are affected by this is mitral valve is the most common, then the aortic valve, and then over to the tricuspid valve. Okay, so mitral valve is the most common valve that is affected by this disease, this disorder. And we talked about how the risk or the population that gets acute rheumatic fever is the population who's at risk of developing strep tonsillitis. So this is going to be your pediatric young adolescent populations because that's the population at risk of getting strep. Okay. And we talked about how globally this is a major disease burden, but in industrialized nations like the United States and Europe, this is an uncommon thing because we have access to medical care, we have access to testing for this condition, but we also have the antibiotics necessary to treat strep throat. Okay? So the best thing that you can do to prevent acute rheumatic fever from ever developing give your patient antibiotics, penicillin-based or a suitable alternative if they're allergic to penicillin, that will treat the strep throat. Okay. When somebody does present with acute rheumatic fever, remember they may have just kind of some vague kind of symptoms associated with this. So Jones criteria helps you with the diagnosis of acute rheumatic fever. And the first thing that has to be present for Jones to be positive is there has to be evidence of a previous strep, group A strep infection, okay? So you've got to have that. If you cannot demonstrate that there was strep, then this whole thing falls apart and you can't really give that diagnosis. Otherwise, if they do have that history of strep, then they need to have 2 major criteria or 1 major and 2 minor criteria in order to have the diagnosis of acute rheumatic fever. And when we looked at the major criteria, fortunately the letters in Jones can help you with remembering the symptoms that you're going to see. So the J stands for joints, or this polyarthritis, migratory polyarthritis, where it affects large joints. This is the most common symptom your patient's going to have with acute rheumatic fever. And typically we don't really need to do anything to treat the joint pain specifically, because it's going to go away in its own. We need to do other things like antibiotics, but we don't necessarily need to treat this pain, it will go away. If you change the O to a heart, then that's carditis, which is the second most common symptom, which this developed because there's a cross-reactivity between the antigen of the strep bacteria and the antigens on the cardiac tissue. So you're kind of having like this autoimmune kind of reaction that causes this damage to the cardiac structures. And because there's like all 3 layers get impacted and get inflamed, you may see symptoms similar to like a pericarditis, like a friction rub and those kinds of things present in these patients, okay? And then because this autoimmune reaction can attack the valves of the heart, you may start to notice some new murmurs that develop. And they could be either stenotic murmurs or regurgitation murmurs, or both. Other things to note is the murmurs in the acute rheumatic fever phase of this, they are transient. So they develop these murmurs. Once that inflammation gets better, then those murmurs will go away. It's transient in nature, okay? The N is nodules, which is this firm, painless nodules. This is the least common of symptoms, though. So don't expect to see this in all of your patients with rheumatic fever. The E is erythema marginatum. This is more common than the nodules, but still an uncommon symptom. But you can see this rash, which looks very similar to a tinea or a fungal rash, which key things that kind of distinguish this from a fungal is this non-pruritic, non-painful eruption. Okay? Otherwise, it looks like a fungal rash. And then probably the most severe symptom, which occurs in 20% of patients, is the Sinahan's chorea, where they develop this rhythmic, uncontrolled kind of tick or twitch of the extremities. They tend to last, these symptoms tend to last for about 3 to 6 weeks. But you can imagine how distressing this would be to a patient if they were to have this symptom develop. And then when we talk about things that help you diagnose a strep infection, so you could have like a positive throat culture or a rapid strep test to kind of show that. But if those are negative, then you can do the antibody testing to help you differentiate or to detect a recent but not active infection. But if you are still questioning whether or not this patient has acute rheumatic fever, they can do a cardiac biopsy, and there's this specific thing that they find, which is these Aschoff bodies that will be present on that biopsy. The key thing, though, when you're treating acute rheumatic fever is antibiotics. Antibiotics, give them antibiotics that will treat group A strep. And then you need to give them an anti-inflammatory medication. And they need to be on high doses of this anti-inflammatory or high doses of aspirin to manage that inflammation. Even in your kids, you are going to give them high-dose aspirin. We're not going to really be concerned about Reyes syndrome. We monitor for it, but the risk of Reyes does not outweigh the benefit of giving them aspirin in this condition. And then these folks tend to need prophylactic antibiotics against future group A strep infections, because if they had acute rheumatic fever developed once because they got group A strep, then they are even at a higher risk of getting another episode of acute rheumatic fever with a subsequent group A strep infection. So typically these patients will need, maybe 20 to 40 years of prophylactic antibiotics, which could be either a daily medication or a monthly shot of like a penicillin in order to treat and prevent group A strep infections in the future. Then we talked about how patient has acute rheumatic fever, then 10 to 30 years later, they could develop rheumatic heart disease. And this is the chronic version of this. And this is a permanent damage that occurs to the cardiac valves, okay? And it's because the damage was kind of done, it was transient in nature, but then scar tissue kind of starts getting laid down, and that leads to this permanent but chronic damage, okay? And we talked about how mitral valve is the most common valve damaged by this, but aortic is a close second, and then tricuspid being the third most common valve affected by this. But then that led into us talking about mitral stenosis, and we talked about mitral stenosis is in the world is most commonly caused by rheumatic heart disease, but in industrialized nations, that's not as common because we just don't see as much of rheumatic heart disease in the first place. So we start looking at other things like congenital stenosis or severe annular calcification, like your atherosclerotic patients. And what happens with this is that mitral stenosis develops. You get that resistance to open the mitral valve during diastole, when you should be getting like that passive flow of blood from the left atria and into the left ventricle. That leads to higher pressures, higher volumes in the left atria to force that valve to open. And unfortunately, with that higher pressure, higher volume, it then backs up into the pulmonary system and leads to that pulmonary congestion and heart failure kind of thing. This is worse with like conditions like AFib because you lose that atrial kick, so you lose the ability to generate a actual like higher pressure state in the atria to open and maintain that mitral valve to be open. Symptoms of this are going to be either your pulmonary symptoms, so dyspnea on exertion, or orthopnea, peripheral edema, all those kinds of things will be present with mitral stenosis. The murmur for it is this decrescendo, crescendo, diastolic murmur. So the pressure differential is going to be the highest at the opening of the mitral valve, and then as that volume starts to leave the atria and goes into the ventricle, that pressure differential starts to shrink, get smaller, that reduces and slows down the turbulent blood flow, and you get that decrescendo pattern, and then you get that atrial kick, which then increases that pressure differential, and then you get more turbulent flow before the mitral valve closes to start systole. And that's best heard, where is it? Apex of the heart. Okay, so the mitral auscultation site. Other things you might find, so on your EKG, you're going to have left atrial enlargement, but you're not going to see left ventricular hypertrophy because the ventricle itself is unaffected by this. Whatever pressure, whatever volume of blood gets from the atria to the ventricle, it's going to be able to easily handle it. The problem is that valve is resistant to opening. Okay, so you get that P mitrale. You may have right-sided enlargement, depending on how bad this is and if it's backing up and affecting the function of the right side. But the left ventricle will be normal. Echocardiogram, test of choice, you'll be able to see that this fish mouth appearance you see here. And the way we treat this is, because this tends to be a volume overload state because you're not moving that volume forward, let's do things like salt restriction, let's do things like diuretics, let's also do things like beta blockers in order to increase my diastolic filling time, okay? To try to get more volume out of that left atria and into that left ventricle, okay? But ultimately, especially if they have severe symptoms, then ultimately the treatment for this is going to be to fix the valve. And the preferred way to fix the valve is to do this percutaneous mitral balloon valvotomy, where the balloon goes into the mitral valve, they inflate it, and it pops that, those adhesions of the leaflets open so that it can now flow normally. But there are complications to doing that, and so not everybody is going to be a good candidate to do that balloon valvotomy. So for folks who are not good candidates, then we have the actual valve replacement as an option to treat this condition. Okay, and there's two versions of the valve replacements. There's the biologic, and then there is the mechanical options. And there's advantages and disadvantages to both. So these patients, in selecting which one you put in your patient is going to be really dependent on the patient and their risk factors, life expectancy, and those types of things, okay? If you have a patient who doesn't have very long to live, and or they cannot be on anticoagulation because of falls risk or occupational hazards or whatever, then a biologic heart valve is preferred. They don't really last very long, but you don't need anticoagulation with the biologics. If you have somebody who is younger, who has a longer life expectancy, and they can tolerate being on anticoagulation, then you would want to do a mechanical valve because these can last extremely long. Remember the news story I showed you where it lasted almost 50 years in that patient. But she needed to be on anticoagulation for her whole life because the mechanical surface of that valve is prone to developing clots. So they need to be on anticoagulation to prevent that. Then we talked about mitral regurgitation, and we talked about how with any regurgitation condition, there are primary causes where the valve leaflets and the valve structures are the problem. But we also talked about how there are secondary causes where something outside of the valve or its components leads to this regurgitation to develop. And we talked about how also that there are acute physiologic changes and there's chronic physiologic changes, and the presentation of that acute versus chronic is going to be very different, okay? So what's going to happen? Well, because I have this regurgitation, volume of blood that gets into the ventricle, instead of it staying in the ventricle and leaving the aorta, it's going to then flow back into the left atria, which then leads to a higher volume and a higher pressure in that left atria. Because I'm also losing a lot of that volume going in the wrong direction, I'm going to lose cardiac output from the left ventricle. And then ultimately, all that volume that went back into the atria and has since reaccumulated because of a return coming from the pulmonary veins, all of that is then going to lead to problems affecting the left ventricle as well. With acute causes of mitral regurg, you're looking at things like rupture of the infarcted papillary muscle, where everything's fine and all of a sudden that papillary muscle ruptures, or that chordae ruptures, and now you have that valve leaflet just kind of flapping in the breeze. Chronic would be something that slowly progresses and impacts the function of the valve. So like your rheumatic heart disease, it's a slow growing process, takes 10 to 30 years to happen, right? Maybe that's going to be more of a chronic kind of cause. And the pathophysiology is going to be very different between the two. So in mitral regurg acute, you're going to have a quick elevation and pressure of the left atria and a higher volume in the left atria, which then is going to lead to pulmonary problems and lead to pulmonary edema and congestion. Okay? Now it does also have a cardiac output problem, but that flash pulmonary edema is going to be life-threatening almost immediately. With chronic mitral regurg, the atria has the time to develop compensatory mechanisms to accommodate that extra volume so that that pressure does not rise as quickly, okay? And with that pressure not rising as quickly, it doesn't tend to go back into the lungs and the circulation of the lungs as much or as easily. So the primary kind of presenting symptom with this is going to be your decreased cardiac output, so your exertional kind of things, okay? And the murmur for this is going to be, if it's acute, this early to mid-systolic decrescendo quality, but if it's chronic, it's going to be this holosystolic murmur, okay? Because that pressure is not going to increase rapidly and stop the flow of blood in that chronic thing like it does in the acute, because that acute, that pressure is going to rapidly increase in the atria, so it's going to stop the flow of blood from the ventricle into the atria. Now with the EKG, you're going to see both left atria and left ventricular changes with this condition, because this does impact the ventricle itself. And then chest x-ray, yeah, you may see an enlargement of the heart. You may also see some pulmonary edema, depending on if this is acute versus chronic. Echocardiogram is going to be your test of choice. And the treatment for this is going to depend on if this is acute or chronic, okay? Acute, I need to aggressively reduce that afterload to encourage more cardiac output and less of that regurgitation. But I don't want to necessarily do things to slow down the heart rate because I want to get that forward flow, get that systolic circulation going. If it's chronic in nature, and ultimately you have to fix the valve. So you got to fix the valve with this if it's acute, or else they will die. Chronic depends on if it's primary or secondary. If it's primary, meaning that the valve leaflets is the problem, then we may need to repair it or replace it. If it's secondary causes, things from like left ventricular dilation or enlargement, similar to like dilated cardiomyopathy or something like that, then I want to treat that cause so that I can hopefully get that valve functioning again. And then we finished the first lecture talking about mitral valve prolapse, and we talked about how the definition of mitral valve prolapse is just this hypermobility or this excessive billowing of the mitral valve into the atria. Not everybody with mitral valve prolapse is going to have mitral regurgitation, okay? So the most common cause of mitral regurgitation in the United States is mitral valve prolapse, but not everybody with mitral valve prolapse has mitral regurg, okay? It really all depends on that excessive billowing if it leads to the opening of the valve or not, causing that regurgitation. For folks with mitral valve prolapse, oftentimes they are asymptomatic unless they are having that regurgitation, in which they'll have potentially the symptoms that go along with mitral regurgitation. But one of the things you can do to kind of help you with the diagnosis of this is doing dynamic maneuvers, which will alter when the murmur is present. Okay, when that clicking of the billowing is present, and then if there is the mitral regurgitation component to it, when you hear that. If I do things to decrease preload, then the click and the murmur occurs earlier. And the reason for that is if I decrease preload, the cavity size of the left ventricle is going to be smaller, so now I have less tension pulling on the chordae to resist that billowing and opening of the valve. If I do things to increase the venous return, so now I'm increasing that ventricular cavity, now I have a lot more tension and counter resistance on those chordae and the valve leaflets to keep them closed longer. So that will then delay the murmur a little bit, okay? So just by doing the changes to preload, decreasing and then increasing, you'll see that murmur occurring earlier or later in the cardiac cycle. And then EKG, okay, maybe normal echo will actually allow you to visualize it. So echo is going to be your test of choice. But ultimately, the treatment for this is reassurance in the vast majority of patients. Okay. The only time that we really become concerned is if this regurgitation is so bad that it leads to symptoms, but then you're going to follow the same guidelines for mitral regurgitation in that case. And then just remember, back in 2007, we stopped giving infective endocarditis prophylaxis with patients with mitral valve prolapse who are undergoing high-risk dental procedures. So let's go ahead, we'll take an hour, come back and finish up or continue on our review.